Thank you very much. And this is a very different spin from the rest of the posters here. As most of you are aware, chronic renal disease is a significant complication of type 2 diabetes. Mild renal impairment, the prevalence of mild renal impairment is about 38%, and which increases as we get older to about 48% over the age of 65. So what we did here is, and also we know the impact of mild renal impairment has not been really studied well, especially the safety and efficacy of the anti-hypoglycemic agents in clinical trials. So what we did here is a randomized clinical trial to assess the safety and efficacy of sitagliptin, which is a DPP-4 inhibitor, compared with the dapagliflozin, which is an SGLT2 inhibitor in subjects with type 2 diabetes with mild renal impairment with an eGFR between 60 less or equal to 90 mils per minute. You can hear me? So this is a study design, as you can see here. Patients who are enrolled with type 2 diabetes, and they are either on metformin or metformin plus SU, and also with an A1C between 53 and 80 millimoles per mole, which is 7 to 9.5%. They were randomized to either sitagliptin 100 milligrams once a day or dapagliflozin 10 milligrams once a day, initially started at 5 milligrams, at week 4 up titrated to 10 milligrams. 95% of our study subjects were up titrated to 10 milligrams. And it was a 24-week study. Moving on to our demographic table, it's pretty much similar to other diabetes clinical trials. Age is slightly higher based on the mild renal impairment, 67 years, and the BMI typical of 32, and the eGFR 77 to 79, and the duration of type 2 diabetes about 11 years, and the background medication, 70% were on just metformin, and the combination metformin plus SU about 31%. Moving on to our main efficacy endpoints and the results, I want to focus on the graphs over here. On the y-axis, what you see here is a change from baseline A1C in millimoles per mole, and on the x-axis on weeks, you can see in pink is a sitagliptin, blue dapagliflozin. They improve A1C, especially at 10-week period, and they can continue and sustain the A1C reduction through 24 weeks. What you see here is the group difference is a delta of 1.67 millimoles, which is around 0.15% A1C, and it satisfied the pre-specified criteria of non-inferiority and superiority. Furthermore, one of our secondary endpoints is the percentage of patients who get to goal of an A1C of less than 53 millimoles per mole, which is 7%. As you can see clearly, the pink bar is the sitagliptin, about 16% achieved 7%, they got to goal more than the DAPA group. And in terms of baseline change from baseline, the systolic blood pressure and body weight, as it is well known with the SGLT2 inhibitors, DAPA had the better blood pressure reduction of -3.3 and body weight of -2.4. Moving to our safety endpoints, the adverse events, pretty well balanced in both groups, except for the drug-related AE. As you can see, the drug-related AEs were higher in the DAPA compared to the SITA group, which was predominantly due to infections. You can see the confidence interval doesn't cross 0. So in summary, our conclusions, what we did in our study in patients with type 2 diabetes with mild renal impairment, treatment with sitagliptin for 24 weeks resulted in greater improvements in A1C compared to DAPA, and it was pretty well tolerated.